have now idea about our overall organization and what eventually topics we cover, but as I mentioned, we also celebrate today 40 years of Dr. Moss's contribution to this particular field. And let me say a few words about Dr. Moss. I had pleasure and honor to work with Dr. Moss for, as I mentioned earlier, 27 or 6 years before he passed away. And I was really blessed with amazing mentor, and I learned on long QT everything I could from him with his extremely generous educational abilities and with amazing eagerness to break new ground. But let me say a few words that Dr. Moss is not only long QT, and I will start with a few slides about his other accomplishment, and we will focus on long QT next. So you may not know, but in 1962, Dr. Moss published a paper in New England Journal where he showed that regular cardiac chest massage, like you do now in CPR, is able to resuscitate people after ventricular fibrillation, myocardial infarction. This was one of the first cases in the world of this type of resuscitation. So even early after his training, because this is when he just finished his training, he started making the waves. And if you look at this rhythm and subsequently successful massage and defibrillation, he showed that this could be done, and successfully patients were treated. His amazing research focused on risk stratification. This is what Ilan mentioned a moment ago. We all wanted to see, what about these post-infarction patients after heart attack who have damaged heart? How much damage will eventually be associated with increased risk of mortality or sudden death? And this particular paper, published by Dr. Moss in late 1970s, is really the most landmark paper, which is quoted by people more than 15,000 times, because it shows that there is really curvilinear relationship, and this ejection fraction which you have on x-axis is a measure of how LV, left ventricular or heart is pumping, and if it's lower, meaning that it's higher risk, as you see. And this was really the most important development, which led to numerous trials which you heard a moment ago, and I will mention them too. So again, not really focusing at this moment still on long QT, Dr. Moss, immediately after all those discoveries, he became already aficionado of the concept of implantable cardiac defibrillator. He already did work on external defibrillator and cardiac massage, and in 1973, he met and became good friend with Dr. Michel Mirowski on the right, and Dr. Mower on the left, who invented implanted cardiac defibrillator. This is the one which some of you have. They were pioneers in the field, and they, at certain stage, started working together, mostly in closer to 1980s. And the first defibrillators were, in fact, in early 1980s implanted. This type of defibrillators, obviously, are like the one on the left, which is now transvenous, used to be transthoracic, and the novel models are without lead in the heart, which is so-called subcutaneous. So speaking about those, and Ilan already mentioned, first major study of Dr. Moss was called, as we call it, MADE IT, which tried to identify high-risk people who had heart attack, who had some arrhythmia which could be caught on Holter, and thereafter they were subjected to some electrophysiology testing in the lab, and if they were still inducible with arrhythmia, they were randomized to transthoracic initially, it meaning with open chest, because this is what happened in 1991, ICD versus no defibrillator. And as you see, these two curves represent the probability of events or probability of survival. And if we look at this curve versus this one, there is huge difference. which happened to be about 40% reduction. So what we did next, and I'm saying we because I was co-PI of this trial, which launched in '97, we did the same but in wider population. Made it 2 was the study which took people who didn't have this arrhythmia. They just had poor ejection fraction, poor function of the heart. And we showed 30% reduction, which became really standard for current indication of defibrillators worldwide. And I could tell you that this indication is covering probably about 70% of ICDs implanted worldwide based on this trial. So only in United States we have about 100 to 120,000 implanted every year. So maybe 70 out of those are because of this study. And another 15, 20,000 because of this study, which included also so-called pacing of the heart to make it working better. So on top of having defibrillation, there is an option that somebody could have left ventricle paced like with pacemaker, and this pacing is causing better pumping. So this is what we show that it really works well, and everything obviously was led by Dr. Moss. And we also had some other study which focused on inappropriate therapies. You all heard about the issue with inappropriate therapies, whether caused by atrial arrhythmias or by fracture electrode, or you name it. We wanted to eliminate or decrease them, and by intelligent programming approach, we were able to show that it works well, and it could be diminished tremendously by pretty much 80%. So now let's switch to long QT, because this is our main melody of today. So in 1971, Dr. Moss published this paper, which showed that this, it's called sympathetic gangliectomy, and now it's more like sympathectomy or stelectomy, but we speak about the same, is able to reduce QT duration from more prolonged here to practically close to normal here. And this was really important discovery, because until 1970s there was no treatment, good treatment for this disease. This was rare disease, first of all. Second, there was no access to beta blockers. Beta blockers were not yet widely accessible at that time. They were discovered in 1964, but not yet ready for widespread use. So what happens that this patient, who's supposed to be here today, and she's 90, but she, because of some issues with in the family, she couldn't manage today. We were very much welcoming her. She, every time she was bowling, because she loved bowling, when she got excited, she got some syncopal episode. So this bowling was, you know, she came to Dr. Moss and she said, I love bowling, what I need to do really to make it better. And Dr. Moss, together with Dr. McDonald, who was vascular surgeon, they agreed that probably cutting some of the nerves here under, let's say, neck, which innervate heart, like diminishing stress catecholamine, so-called, so biomarkers which elevate your heart when you are stressed. When you cut them, you will diminish this effect of stress, in this time emotion, on the heart. And it worked, and it worked. It was really the first case ever in the world. It was published in New England Journal at that time, and this pretty much opened the story, because all of a sudden, after his paper was published, people from all over the country and even beyond started calling him, email was not yet around, and started asking, okay, maybe you could do it also for my patient, or maybe you could do for me if patient was calling. And altogether it happened that he figured out, oh, so many patients all of a sudden has long QT, I didn't know about it, let's start some registry. And this is what next happened. And pretty much in 1979, Dr. Moss, together with Dr. Peter Schwartz, and Duncan, I think, met Peter in Milan before. So they established this so-called International Long QT Registry, and we had at that time colleagues from Italy, from Rochester, and also subsequently from Israel, and this was called International. And over the years, we've done a number of other collaboration with Denmark, with Netherlands, Japan, and so on. So currently, we have 1,052 probands, and probably you know what is proband, but not many people generally know. Proband is the first member of the family who is identified with a given rare disease. So we have 1,050 families with about 6,700 family members. There are even more family members who are not affected, who are not really active because they don't need to be active. But this is our basis for our current research, and only because of your huge commitment we could do it. And following on Dr. Moses' accomplishment, shortly thereafter, 91, you have some first major analysis of 300 families at that time in 1991, showing that there is big risk for probands, but still significant risk for so-affected people with QT above 44, and here are undetermined and so on. So you see that there are first attempts to look at risk stratification. There was a lot of interest in ECG and how we could eventually identify these people better, and a lot of interesting work was done on how we can diagnose patients with this disease. And we spoke with a couple of people yesterday evening about pregnancy. And what we did in this particular study, which was so relevant for every long QT family, how to evaluate this patient who want to have children or who have children. And we look at risk of events, starting with pre-pregnancy 9 months, pregnancy 9 months, and postpartum 9 months. And as you see, there is huge increase in postpartum period. And this paper from 1998 was really the reason why we were able to recommend that, especially during postpartum period, all long QT patients need to be compliant with beta blockers. If they are not, there is huge risk of sudden death and mortality. And I believe this was a very well received study. In 1998 also, we published first genotype phenotype association, as we call it. So we look at genetic forms of disease and try to see what are the risk of cardiac events. And it was really, at that time, 20 years ago, very unique and monumental job, because it was not done ever before, because only in 94, 95 we learned about new genes. So this was the first kind of work, and this already led us to important identification. And shortly thereafter, or even a little bit before, but on ECG, we look at different forms. This happened to be LQT3, this is LQT2, this is LQT1, and we look at morphology. So you are not expert in the field, but if you look at these 3 different curves, you see they are different by eye. This is much longer QT with different T wave, or here is different T wave, and also here is much wider than this one or this one. We started quantifying it and looking at it, and we are now here, 20 years later, we can say that we can identify with high probability type of genetic type based on morphology of T waves. We also analyze differences in sex and by age. So you have examples of people who are age 1 to 16, and here 16 to 40, and you see that here males are at higher risk, whereas females are above 60 in LQT1 and LQT2. These are 2 examples, so age matters a lot. Finishing and going to 2008, Ilan asked the question about many other good questions he asked, and number of papers which we publish. What about after age 40? So far in our research until that time, we focus on people from birth to age 40, because we said, okay, later on, after age 40, people develop hypertension, maybe at 50, 60 diabetes, coronary disease, number of things which may affect our judgment on whether some events are truly due to genetic disorder versus acquired disease with aging, okay? And what was shown, in fact, by Ilan and many investigators you see here, that in fact QT above 470 patients were still at higher risk despite all these background diseases. So this was very important, that we need to pay attention to long QT patients, not only in childhood, not only during adolescence, but we need to pay attention to them also all the way in the even elderly age. And there was subsequently a lot of interest in treatment. So we've done very important work on beta blockers, where we advocated that beta blockers are very effective in treating LQT1, LQT2 patients. LQT3, we were not sure at that time whether it's working that effectively. And we showed that LQT1 particularly well responds to beta blocker. We also showed that doesn't have to be huge dose of beta blocker, despite initial concepts that larger doses are needed. We subsequently look at ICD therapy, implanted cardioverter defibrillator, showing that it helps, and we have subsequent work done until today, which Spencer will share you the table, which was produced just a week ago. And we also look at novel concept of new treatment like sodium channel blockers, and we'll talk more about it later. What is also important that we try to collaborate with other people. As I told you, we deal with rare disease. Rare disease means that fewer subjects, especially with heart events like sudden death. So Dr. Moss, Dr. Shimizu from Japan, as well as Dr. Wilde from the Netherlands, they created kind of consortium on combining three databases. And what we did all together, that we try to first focus on long QT1 and look at certain aspects of it, including location of mutation. The same was done in LQT2. LQT3 took some more time because it's fewer, as you probably know, accounts for about 5 to 8% of long QT, whereas the other types about 40–45%. So this was fewer, but very important study we will mention later. And finishing, I would like to say that we continue to work on it. Just a year ago, we worked on a new scoring system for risk of patients who might get ICD for syncopal episode, not for aborted cardiac arrest, and which was very well received. And I would say that what I gave you in your folder, this is really very interesting paper and recommend you read, which was really written by entire family, and you, I hope, will appreciate their commitment, not only Dr. Mo's entire family, to the topic. And we will talk about various research today, but just to make sure that you understand that we continue with this research and legacy of Dr. Moss, lasting right now for 40 years. So these are papers which we publish or are in press in just 2018-19. So here are some work on genotype-specific risk stratification. We look at what about antidepressants in long QT patients. We found that everyday emotion may influence QT prolongation. We published this year ago. Risk stratification ICD, the paper I just showed, some aspect of ECG. There is grant, which we are finishing right now with so-called pluripotent stem cells in long QT, which is way to attack the disease. We are also finishing analysis of the study conducted by us on the drug coranolazine in long QT3 patients. We have this paper appearing probably next week in Circulation Arrhythmia, showing that atrial fibrillation is totally different in long QT patients. It's another arrhythmia, but one surprise, LQT2 patients, they don't have AFib, some protective effect. There are some psychological factors which are being analyzed now. You responded to many questionnaires over last year. The new data on effectiveness of ICD therapy, which we just finished. We created new risk calculator to predict life-threatening events. We have this under review, and in few months we hope we will have it published. And Dr. Ilan Goldenberg just received American Heart Association grant to focus on sex-specific differences, and he will say a few words about it later. So this is overall summary of really 40 years of research by Dr. Moss, or 50 almost, counting from 1970-71, and our group is really committed to carry this torch forward, and we believe we are successful, but we wouldn't do anything of it if not you